Hello everyone and welcome to Healthline 3. I'm Terri Simmons. Today we're talking with Dr. Michael Banda of Willis Knighton Bossier Surgical Associates about abdominal pain. And we'll be taking your calls throughout the show, and as a reminder for you, please make sure you're in a quiet room with your TV turned down very low volume, and when you call in so we can hear your questions. The number to call in is 318-219-4569, and you'll see that at the bottom of your screen throughout the show. Thank you so much, Dr. Banda, for being with us. We appreciate it.
Thanks for having me.
Well, let's start a little bit about you. Tell us about what is your surgical specialty? Tell us about you.
I'm originally from San Antonio, and I did my undergrad at Baylor University in Waco. Went to medical school in San Antonio, and I've been in Shreveport since 1991, where I did my surgical residency at LSU Health Science Center on Kings Highway under the late Dr. John C. McDonald. Ever since finishing in 1998, I've come out to private practice in Bossier City at the Willis Knighton Bossier Health Center for the last 22 years. I do travel up to North Caddo Hospital in Vivian, one of the Willis Knighton affiliates, to do minor surgeries and to do clinics as well.
And is that what brought you here, wanting to study at that place and with under this doctor? Is that what brought you here, wanting to study there? Or
yes, I came to this program because of the big reputation that Dr. McDonald had, and obviously us residents who finish there get a great surgical education and experience.
Mm-hmm. And did you always want to go into general surgery, or how did you know that's what you wanted to specialize in?
When I was in high school, I knew I wanted to go into medicine, but it was like during my third year in medical school where the pieces of the puzzle lined up, and I felt like general surgery was a field of surgery that complements everything about me.
Oh, that's so nice. Well, so tell us about general surgery. What does that cover in the body?
General surgery covers, it's a wide variety of operations. Obviously it's not orthopedic surgery, neurosurgery, or cardiovascular surgery, but there's a lot of things in the abdominal chest region that general surgery encompasses. For instance, intestinal issues, hernias that can develop over time. We do perform small procedures like excision of lumps and bumps or drainage of abscesses. Kind of a wide variety of small cases all the way to very big, challenging cases involving the colon, in general, the digestive tract.
Yes. And so as a general surgeon, do you handle elective as well as non-elective surgeries?
Yes, I do. I would say on average, a general surgical practice is half elective and half urgent, meaning that I may start off with 5 cases scheduled for day surgery, end of the day doing 10 cases. Half of them come in through the emergency room or being admitted on the ward by other physicians.
And what's an example of an elective surgery when it comes to
an elective surgery could be like an inguinal hernia. A person comes in and there's a lump in their groin that's been causing pain or perhaps getting bigger. That's a classic case for an elective surgery. Or if someone has gallstones and they hurt intermittently but not very severe, we'll take them to outpatient surgery. Likewise, an inpatient non-elective case, we might have someone come in with appendicitis. They showed up to the emergency room, severe pain, and we end up operating on them and doing an appendectomy.
Oh, goodness. And so is it like it sounds? Like some people, you tell them they have a hernia, they might be in pain, and they might still elect not, it's their decision? They might decide they don't want to have surgery?
Yeah, in general, most hernias ought to be repaired. Mm-hmm. They just will not go away. Eventually they'll get bigger, cause a problem, and what could have been a simple, straightforward outpatient procedure now turns into a bigger operation, more downtime, more inconvenience, more pain for the patient. So yes, if one has a small surgical issue and one has a time and convenience, it's probably best to get it taken care of before it gets to be too big.
Because technically, what is a hernia? What is that exactly?
A hernia is basically something from within the abdominal cavity poking out. It could be a loop of intestine, part of the colon. It could be a part of the fatty tissue from within. A hernia is a weakness in the abdominal cavity or groin. There are some natural weaknesses throughout the body. Or it can be from previous surgery where an incision has broken down, stressed over time, and now something's popping out. Size of a golf ball, or sometimes even bigger, like a grapefruit size mass. So that's what a hernia is, something coming out where it shouldn't be out.
Okay, and there's several causes for that. There are some weaknesses. It's not always something that you do to cause that. It's just something that happens sometimes.
It can happen. We do have inherent weaknesses throughout our abdominal cavity. Of course, some patients are more strenuous workers, might be more prone to developing hernia. But in general, it can happen to anybody. I've seen it all across the board in patients who are not lifting much, or to those who are heavy lifters, strenuous workers at work. In general, a hernia, things inside the abdomen should stay inside the abdomen.
Right, just simply said, they should stay put.
Right.
Yeah, and I think that's true. Growing up, I always heard that it was caused by lifting something heavy. That's what we've always heard, a hernia, you lift something and it pushes through like that. But I never knew that there are just generally maybe some weakened areas. Everyone has some weakened areas throughout the abdomen where that can happen. So what are what are the most common underlying causes that you treat?
Abdominal pain encompasses a wide variety of possible problems. Starting in general, when someone has abdominal pain, it could be kind of diffuse everywhere, non-specific, something patients can't put a finger on. And a lot of times we all experience things like this. It could be gas, it could be something we ate. But when it gets to a certain point where, wait a minute, this gas, this cramp, this is just not helping, it's not getting any better. In fact, it's getting worse, and I'm starting to have a fever. And what used to be several hours prior with pain everywhere, now it's kind of pointing in a pointed direction. And so when things get past the ordinary that we're accustomed to, it's really time to either get to your physician's office. If you can't be seen in a timely fashion because of the backlog, busy schedules of physicians, then the emergency room is always open. And one can get to the emergency room, get evaluated sooner, get tests performed, so that the issue could be resolved or at least identified.
Right, especially if you're in pain. If there's some pain and you can't get in to see your doctor, go to the emergency room. That's something to go in and to see about.
That's exactly right.
Yeah.
Once the home remedies have been surpassed, then it's time to get serious about it.
Let somebody look at it. And what are some of the things, I know there's times where we'll go to the doctor and they'll ask questions like, where does it hurt? And we can't think in the moment where it hurts, or if we've had any fever. What are some of the things that we can make a list of to tell you before we come see you when we've had abdominal pain?
Yeah, then that's very helpful. That's a very good question. When you come to see a physician, whether it's in the office setting or emergency room setting, kind of have a historical perspective as to when did this pain start? What were you doing? And what made it better, or what made it worse? Did you take anything that really improved it, or something that made it worse? Also, more or less, where did it start? Maybe the grade. Maybe it started as a number 1 or 2 in pain. Now it's a 5 or 6 or 7. Something that you've never experienced before. Anything that would be helpful in helping the doctor decide to try to put more definition to what's going on.
Okay, so it's good to know. Good to have that list ready for those questions.
That's right.
Because sometimes it's hard to think in the moment. Yeah.
Yes, it is. Patients come in very ill, very painful. If you run a fever, you may not be thinking correctly. Sometimes if you're dehydrated, you're really not wanting to verbalize much of anything. So just have a list of little things that could help the doctor decide It's looking like this, but let's go ahead and order certain tests to prove that.
Okay. And is it a good idea if you really are in severe pain and you don't feel like talking, it's just you're sick and you want to get out, bring someone with you who has that list, who can answer for them and also listen for them? Is it good to have someone with you?
It sure is, always, no matter what, because you don't know if you're going to have to undergo a procedure that requires sedation. It's always best for someone to, either a significant other or a parent or a sibling, someone who can at least verify what you're telling to the physician, someone who has been another set of eyes and ears as to witnessing what's going on, so that the picture could be painted in a brighter way, so that action could be directed immediately.
Sure. Okay. And it's good to have 2 points of view probably while they're in there and really listen.
It certainly is, yes.
It's good. And that second pair of ears too, to remember what you tell them. So tell us about the diagnostic workup and treatment for gallbladder. We can take gallbladder first and then maybe talk about appendicitis.
Sure.
What do you do when you're suspecting maybe it's gallbladder?
Most patients who come in with gallbladder disease, of course, there's a broad spectrum of signs and symptoms, but in a typical sense, someone might be out eating, and shortly thereafter, one might start feeling a little nauseated, maybe some feeling of bloatiness, maybe cramping of the upper abdomen, and quite often patients will have maybe some pain either up underneath their chest or to the right side underneath their right rib cage. That's where the gallbladder is located at, and the gallbladder, when it flares up, it may be due to stones or just without stones. I've seen all kinds of scenarios, but generally in gallbladder disease, the pain usually starts on the right upper side, but not always, but most of the time it does.
Okay. What about appendicitis?
Appendicitis, of course, when I see the patient, they're usually hurting on the right lower abdomen area. Now, appendicitis comes in all forms and varieties as well. We operate on patients as young as 6 years old for appendicitis, and some as old as 86. In general, a patient who is experiencing appendicitis, they might feel like they're losing their appetite, they're not very hungry, they're withdrawn, it's almost like feeling like a little virus coming on, but there's nothing really specific. Maybe the entire abdomen is a little cramping, maybe a little low-grade fever. But as time goes on, sometimes that pain, instead of being generalized, kind of shifts down to the right lower abdomen. And that's exactly where the appendix lives. And so when that happens, there's usually intense pain, especially when I examine a patient. They'll almost push my hand away. It hurts them so bad. That combined with some nausea and vomiting, that sounds like a pretty good case of appendicitis that one might be having. Okay.
And what causes appendicitis? Is there anything we can do to prevent getting that, or is it just something that happens? How does that come about?
Well, the appendix is like about as big as my pinky. It comes off the bottom part of the colon called the cecum. It is the opening to the appendix does drain into the colon. Now, it's no one really knows for sure, but it's thought that sometimes the lining of the appendix will swell up, either because of some infection in the bloodstream, or one might have some hard stool that can potentially block the opening to the appendix. When that happens, the appendix past that point of blockage, the fluid within the appendix can't empty back into the colon, therefore it starts getting bigger, swollen, which leads to inflammation and pain as well. If that process goes on long enough, perhaps another couple extra days or several days, then one can have a rupture or a microperforation, as we say, and develop an abscess. And that's a whole other set of issues right there. So it's best when one feels symptoms like that, one ought to get attention pretty quickly, because what could have been a real easy fix now turns into a big, challenging picture of possibly a bigger surgery, an open surgery, more downtime. It's just not worth waiting in a situation like that.
Right, it's just not worth it. Just come in and get it taken care of, get answers.
And case in point, and I always applaud patients when they come in early or soon. I never criticize a patient for coming in for abdominal pain. You just don't know what it might be.
Right.
So, but always, I would rather, and any general surgeon probably feels this way, we'd rather operate on someone who has an easy early appendicitis, because it's, number one, it's easy on the patient. Number two, it's easy surgically. And number three, they end up going home a lot sooner. Versus a more complicated case of appendicitis. It's ruptured, infected. If it's bad enough, we can't perform the laparoscopic procedure like we would like to, which involves 3 small laparoscopic incisions. Now one has to have a bigger operation with incision up and down the middle of the abdomen in order to get the big mess out of there and get the appendix removed. Every once in a while, a patient does have an abscess, and I've seen a few of these lately, where it's not wise to just go into surgery and remove it. As long as the patient's exam is stable, they seem to be improving on antibiotics, we'll have that abscess drained with the help of a radiologist and a CAT scan. And after that appendiceal abscess is drained, then perhaps maybe 6 to 8 weeks later, we bring them back electively to do an appendectomy. We call that an interval appendectomy. And the reason for doing that is because if we initially go in when the appendix is bad, most likely they'll need a big operation, a bigger operation involving the colon as well. Versus if we give it time, provided the patient's condition warrants, bring that patient back several weeks later, we can get it done in an elective outpatient setting with 3 small incisions, got the appendectomy done, avoiding the need for a big major operation.
So that's so interesting. Probably some options there that I certainly hadn't heard of before. A lot of times we hear appendix, appendicitis, ruptured appendix. We think it's just like we go in, it needs to be taken, and
Right.
we hear all of this. But there are other options. There are things to prevent having that big surgery. We don't have to always go there.
Right, and the key is early detection, early attention to this problem, and when and parents are great. They see especially their children go through a lot of things, but they can notice different change. This is different than usual. This is not that gut bug that little Sue had before. This is something different. And most of the time they come in where the appendicitis is reasonable to deal with, it's straightforward, and that's really the best cure. We can get in there with the 3 small incisions, take care of the child or adult, and lo and behold, the next morning they're likely to go home.
And that's really something I'm glad you touched on that with parents with children. Just really pay attention and watch when you can see a change, if it's a different kind of pain than you're normally seeing. And also just parents not to be afraid to follow your intuition. If your child is telling you they're having a pain, don't worry about going and taking them in. I'm
Right.
sure as a parent, I would much rather hear the doctor say, this was nothing, just you didn't, it's fine. Don't worry about a thing. So going in early, you're more likely to hear some of that, or it's a quick fix, or thank you for coming in early before it led to something else.
And one thing I would really recommend, suggest is that don't worry about the ER wait. You know, I heard this so many times from patients who come in later than they should have. You know, most emergency rooms are busy, but certainly I'd rather put up with a busy emergency room sitting there and waiting, rather than coming back 2 days later and the intra-abdominal issue is worse.
Yes.
So my biggest advice to the public in general is just don't let a busy ER deter you from seeking help. I mean, it is what it is, and it's best to take care of these problems early. It's better for primarily the patient, you know.
Yeah, that's very good advice. I'm glad you brought that up, because so many times you'll hear that. Someone will go, it's too crowded, or they feel like they weren't being seen in time, so they leave. So do you suggest just wait, at least if something does happen and get serious, you're at the emergency room. So
Right.
if something does happen and they see that, then at least you're right where you need to be taken care of instead of go home and wait.
That's right, and over the course of the last, since COVID hit, myself and my partner, we have seen and had to operate on many patients who the process, whether it's a bad gallbladder with gangrene, an appendix that's ruptured or infected, we've seen in patients that have had who presented with worse disease along the spectrum, and they end up having a bigger operation, being in the hospital for much longer than they wanted to, and more downtime, more post-operative pain, more time off of work. So we've seen a lot of advanced cases of a basic problem because of the circumstances of last year, the COVID and busy emergency rooms, patients just really not coming in when they should. And again, my advice is, there's nothing wrong with home remedies and taking care of certain things. We all experience all kinds of issues, nausea, vomiting, diarrhea, whatever. But when it gets to a certain point, it needs to be checked out, and it'll pay off for the better.
Yeah, and that is something to talk about too. And I'm sure our viewers right now are hearing all of this right now, and there's questions coming up about COVID related and how COVID might have affected your practice of general surgery, and anything that's coming up now. Now's the time to definitely call and ask you anything about that. Everything we've touched on so much already. How else did you see COVID-19 affect general surgery and your practice? Your observations about that?
Well, primarily it affected the elective surgeries. It really, because we had to preserve the PPI and equipment and what have you, everybody had to push back on the elective surgeries. So that really delayed a lot of patient care as well. And unfortunately, some of those patients came in with worse problems later. But it is what it is, and we had to triage our facilities and our equipment and all that. So that was a big issue with the COVID time. And then again, like I mentioned before, patients were hesitant to come into the emergency room because of the COVID concerns, and they didn't want to get infected. They didn't want to wait. And so we saw, more advanced situations in surgical patients then. So really, in those two regards, they made it more complicated.
Yeah, okay. Well, speaking of callers, we have Ruthie on the line. Ruthie, what is your question for the doctor?
My question, I want to ask him about the H. pylori bacteria that's in your stomach.
Okay. That's a good question.
Some people have in the stomach.
Yes, the H. pylori bacteria, it does reside in the stomach, and anybody can have it even without symptoms. But when you have H. pylori of the stomach, they can, usually the gastroenterologists, the GI doctors, they'll run some tests or some blood tests, and they'll diagnose it, and they'll put you on a regimen of antibiotics to clear it up. Now, the H. pylori, if left untreated, could progress to something bad like inflammation of the stomach called gastritis, and that can further lead to an ulcer of the stomach. And that can even go further. And if an ulcer ruptures, then one will be bad sick. And all that started from H. pylori eventually. And that's another reason for abdominal pain that we operate on. My partner and myself and other general surgeons will operate on someone who has a ruptured stomach ulcer, and we have to repair that ulcer, wash the abdomen out, and it could lead to something serious like that. But yes, H. pylori is very significant. It does need to be treated, and there's a regimen of medicines and antibiotics to help take care of that. Hopefully one can treat it with antibiotic and not surgery.
Yes. And how was that, Ruthie?
Only way you can get rid of it is to be treated with antibiotic, right? Yes,
there's an antibiotic regimen for that, and again, sometimes the gastroenterologist or any treating physician can draw blood work to diagnose that and treat it, or sometimes patients will have an upper stomach scope done, and biopsies will show that H. pylori bacteria. And when that is detected, then a medicine regimen is put in place for that to clear it up. It's very essential to get that cleared up.
Okay. Thank you.
Thank you, Ruthie. That was a wonderful question.
Okay.
And it's so nice when someone calls in with a question, because chances are that there's so many other people at home wondering the very same thing. So it's so nice to trigger these conversations, because that's something I didn't know that we were going to touch on, those kinds of things.
Yeah, that's a great question.
Yeah.
And you know, in talking about our abdominal pain, that is one of the reasons that we operate on is a ruptured ulcer, a stomach ulcer.
Oh.
And eventually, you know, that was caused by having a H. pylori infection.
Oh, boy, that's interesting. So ruptured ulcers, and you know, we hear about when the appendix, again going back to that, ruptures, and we always hear just in common terms that toxins go into the body, or it's so dangerous once that happens. What happens when you get someone and it's ruptured and things are going on seriously in there? What happens then?
Well, and you know, the intra-abdominal cavity is sterile, and the issue is the inner lining of the abdominal cavity, called the peritoneum, is so rich in a vascular network of capillaries, blood vessels. And so when someone has, again back on appendicitis, or even a cholecystitis, badly inflamed or infected gallbladder, those organs touch the undersurface of the peritoneum or lining of the abdomen. And being that lining is rich in fibers and capillaries, that leads to inflammation. That's where a lot of the extreme pain comes from. You barely touch someone's abdomen, and they'll just almost jump off the table from pain. And so, since the inner lining of the abdomen is so rich in blood vessels, when you have an infection like an infected gallbladder or infected appendix, a leakage or rupture, you basically have bacteria from within the colon kind of spewing out into the abdominal cavity and causing inflammation. All the capillaries will start absorbing the bacteria, and that'll travel in the bloodstream, make one really sick, ill, sometimes out of their mind, obtunded as we say, feverish, a very ill individual. And so the thing to do in those scenarios is we rush to surgery when someone is, as we say, septic. By then they would have had all the IV fluids and antibiotics in the IV. And so we go to surgery to explore them, to wash out the infection, to remove the offending organ. And the hopes is to get them back on track as soon as feasible.
Oh, gosh. So much. And when, say, the gallbladder, when your gallbladder is removed, does that change your lifestyle after that? What it's like? What do you have to do differently when you don't have a gallbladder anymore?
Without the gallbladder, it really doesn't change anything. Now, there are some individuals who claim they have a change in bowel habits, but you know, if you really kind of look at it, they probably had some irregular bowel habits to begin with. Now, in the absence of the gallbladder, the liver continues to make that juice called bile normally, and in response to a meal, say when the stomach stretches out from having a meal, the liver will produce more bile, which travels down the main bile duct, where it empties into the small intestine called the duodenum, and that's where it mixes with food that comes from the stomach and helps in digestion. In the absence of the gallbladder, that process continues. The gallbladder is like a storage sac. It's just an accessory organ, which is non-essential. It stores extra juice or bile made by the liver. Most of the bile needed for digestion is made on the spot instantaneously by the liver at that point in time. So removing the gallbladder, one should continue eating, drinking normally. As usual, we all need to be health conscious, so it's always good to try to maintain a sensible diet. We all love fun foods like pizzas and ice cream and everything else, so maybe some of that towards the weekend, but during the week, or have some moderation. And but other than that, there's really no exclusions as to one can eat after gallbladder surgery. There's really no changes that are going to take place.
Okay, so moderation, Pay attention to changes and don't be afraid to go in early to check on that abdominal pain.
That's right.
Dr. Banda, thank you so much. I've learned so much today and really appreciate you telling us everything, and our viewers appreciate it too, I'm sure. We'll look forward to seeing you here again.
Well, we'll be back,
right.
and thanks for having me.
Oh, sure. We enjoyed it. Everyone else, take care, and we will see you next time.